Hello, my name is Ravi. I'm from My Cancer Haven, and today we have one of the leading authorities in acute leukemia in the country with us today. We're really privileged to have him, Dr. Harry Erba. He's professor of medicine, director of the leukemia program at Duke Cancer Institute, but that just doesn't cover it all. He's chair of numerous committees, including the SWA Cooperative Group Committee that decides on clinical trials in this disease in the United States. So we're really blessed to have him. And we're going to talk today about AML, a provocative title, Farewell to Intensive Therapy. Welcome, Harry.
Hi, good to see you again, Ravi.
So, Harry, just to put it in perspective for our audience, give us the background. Where have we been, and where is this trial trying to take us?
Well, I'm going to start, Ravi, by saying I'm really glad that the title slide here had a question mark after farewell to intensive
Sure,
chemotherapy.
sure.
I've been doing this for 30 years, and much of my career has been to developing less intensive therapies, and to find myself in a position to say, well, maybe not so fast to get rid of intensive chemo is a little weird. But you know how these things ebb and flow in medicine. But you know where we've been since 1973, when Yates first published the landmark article on cytarabine for 7 days and 3 days of an anthracycline, in that case daunorubicin, is that has been our standard of care for fit patients with AML. And we know that this is a tough regimen to go through, even for younger patients. There's a 5% early mortality, typically related to mucositis and infectious complications. And despite many years of trying to improve on the outcomes with that intensive chemotherapy by adding other chemo drugs or changing the sequence, nothing has ever been shown to actually improve on the outcome of our patients with AML in a randomized trial, with the exception of the addition of midostaurin or quizartinib in FLT3 mutated AML. And there is, I think, sufficient data to show that the addition of gemtuzumab ozogamicin could be very helpful for improving survival of patients with AML that have an 821 or inversion 16, the so-called favorable risk diseases. But otherwise, I agree with what's listed here, that the plateau that we've reached a plateau. And recent data has shown even in patients with more favorable risk disease, the overall survival at 5 years is only 50%. And for adverse risk, it's around 10%. So we clearly have a lot of work to do. Now, what has been a blessing really for